There we go. Radio. Good morning, afternoon, almost everyone. It's always hard to follow good speakers, but I'll do my best. I think rotablation is probably the cornerstone of calcium management. It came out in the 1980s. It didn't really iterate that much until the last 5 or 10 years with RotaPro because there wasn't much competition in the market. But, you know, as competition came up, I think we have easier and easier ways of doing calcium modification, and rotablation's become even easier now where you don't really need an assistant anymore. You do single operator rota for the vast majority of cases. But what happens if you still have calcium left over? We were asked questions a few minutes ago, right, about when do you stop, right? When are you done? When do you upsize a burr? But I think as we do more and more complex work, we should probably ask more granular questions like, when do I use a cutting balloon, right? Or when should I use an OPN balloon? We heard, when do I use an IVL versus rota versus orbital? And so, you know, we're at the point now where devices cost money, patients are even sicker, and sometimes having a patient on the table for an extra hour, trying this, then trying that, then trying this is a waste of time, money, and patient health, right? So I think we have to get a little bit better than that. And so this talk about combining two technologies to create better luminal gain that allows you to stent is meant to give you my perspective, backed by the evidence, on when to combine these therapies. But I'm very happy for this to be a discussion. These are my disclosures. So this is a case I did not too long ago. It's not wildly complicated. I mean, Professor Mir Jamal and I, we did a live case here not too long ago. That one was harder than this. It was actually similar. That was a big long LAD too. So this is a 66-year-old unstable angina, multivessel coronary disease with a previous PCI some years ago and high creatinine. So we weren't allowed to use much in the way of contrast, right? Our Canadian units, a creatinine of 200 is roughly a creatinine of 2.1 here in Bangladesh. Seen by surgeons because of multivessel disease, turned down for cabbage. So this is what the angiogram looked like, right? There's a whole bunch of calcium within the LAD. This is after some ballooning and lack of predilatation. And so we tried to consider what the best approach was to treating this problem. So who would IVUS first, then decide? Thoughts? Image first, then decide? Nobody. How about a 2O balloon, then IVUS? I'll go one in the back. How about balloon, then put a shockwave in? It's a nice long lesion. How about rotational? How about orbital? Right, so it's interesting. There isn't a whole lot of votes in the crowd. It's because a lot of people are not sure which peg fits into which hole. Right now, I'll tell you that forget a 2O balloon, an IVUS catheter got laughed at when I tried to put it inside because it was just too tight. So I ended up primarily rota wiring with a rota drive wire, which is their new sort of Asahi engineer-built rota wire that actually can function quite well as a workhorse. So it does save you some money from time to time. But when we think about how to manage calcified lesions, there's all kinds of algorithms, right? There's this one from the Europeans. There's another one from the Europeans that was out of European PCR some years ago. There's this one from Optima. They all look like a map of the London Tube, right? It's impossible to understand this. Who knows who's going to go from up to down to right to left? I look at this and it hurts my brain. And so I try to make things as simple as possible when trying to decide how to manage calcified lesions because the patient's giving you enough challenge. So here is a little bit about when to pick what and where rotablation and a cutting balloon might fit together. So if you have angiographic calcium, if it exists, by definition, you need to image it because once you can see calcium, you don't know if it's a calcium score of less than 1 on IVUS or less than 2 on IVUS, or if it's worse. You can't tell. So the best you can do is get the imaging in place and then try to figure it out. So if you do the imaging, how does that help you? Well, we heard a little while ago about how the use of intravascular imaging in routine practice, certainly in complex lesions, definitely in left main, leads to clearly superior outcomes with 40% differences in heart outcomes, right? 40% differences in MACE. And, you know, we'd be all very, very comfortable to take a 5th generation drug-eluting stent that magically reduced our MACE rate by 40%, right? Who would not want that stent? But that exists. That's imaging. The only difference is we have to learn how to read what we're looking at. So we've appreciated that intravascular imaging cuts bad things in half. So let's facilitate access in this case for imaging. So in this case, I rotated. Okay, I had to take 4 passes with a 1.5 burr because that was a reasonable burr to start with. It was almost a lesion that was almost tight enough on the wire so that I couldn't manipulate the wire. So this was just burring with a 1.5. And then interestingly, we needed bigger, so we took a 1.75 now. And as you can see, I took the 1.75 quite a ways down the LAD, right? It's down past the major bend in the LAD, down and towards the distal vessel. But there's no fear there because it's a big vessel. How do I know that? Well, you do enough intravascular imaging, you realize that there's no such thing as a 2.75 proximal LAD. It just doesn't exist. Doesn't matter if you're Indian, Bangladeshi, Chinese, American, whatever. It's not a thing. And so it's probably worthwhile doing the imaging just to learn that so that we stop putting 2.5 or 2.25 stents in the proximal LAD because that's just terrible. Okay? So we created a bunch of space. Now we put the intravascular imaging. How do we interpret what we see? So IVUS detection of calcium is challenging at times because sound doesn't pass through rock. But that doesn't mean that you can't infer what the thickness of what you're looking at based on the other features of the IVUS, right? So that's where the IVUS analysis of calcium came from, where there was a score developed that defined whether or not you actually had thin versus thick calcium. Now, this is actually a modified version of that score. The true score includes the size of the vessel, the presence of a nodule, the length of the lesion with 270 degrees of calcium, or the presence of a 360-degree arc. But when you add reverberations into it, right, these secondary effects where you see the arrows, that tells you that that calcium is largely less than half a millimeter thick. And that's a very important decision point or division point because there are some therapies that work better on things that are less than half a millimeter, some therapies that work on things that are bigger than half a millimeter or thicker than half a millimeter. And that's where we get to separate our toolbox into this is what will probably work here versus this is what won't work here and we need to do something else. So let's go back to our case. So this was our IVUS after we rotated. What do we see? Right? So this is your distal vessel. What did I say about the size, right? That's a 369 across in that distal LAD. Okay? So now you have a ring, but you see cracks, right? Right here. This is the end point of atherectomy. That is ultimately what you're looking to achieve when you want to start stenting. If you don't have cracks, don't stent. It's going to give you a terrible result. So this was the next one. Does anybody see cracks there? Right, there are cracks here, right? Is this a pointer? Great. So cracks here, right? There's a crack here, right? How about here? Not as good, huh? That's not so good. And what's worse is the lumen here and the lumen here is bigger than the lumen here. So in a vessel then where you have no cracks in the calcium, but with a restrained lumen, that's a recipe for stent failure. And how about here then? This is the proximal, right? So the proximal is pretty big. There's still a ring of calcium here, but now it's 3.76 millimeters across. This is huge. And this is bigger than this. So here you could put a stent in. It may be restrained by the calcium, but the calcium ring is so large you don't have to worry about the stent size. So what this tells us is we have a problem in this section in the mid-vessel. So stenting here will result in an area of severe underexpansion, and we don't want that. So what's the answer then? Well, we go back to our simplified calcium algorithm where we try to use what we see on the imaging and on the angiogram to decide on what the right tool is for a particular scenario. So who wants to shockwave this now? Okay, so let's spend $3,000 on a shockwave balloon. Fine, right? How about just balloon it and don't worry about it? Okay, well, why not? Let's spend $75 on an NC balloon. That's cheap. It won't work, but it's cheap. How about Wolverine? Well, who wants to put a cutting balloon in a bunch of calcific rings? Does that make sense? Is it supported by the evidence? Well, this is my approach to when you start using adjunctive technologies after atherectomy, right? So you have a minimum calcium score of over 1.7. That's when the inflection point happens on the calcium score, where above 1.7 you need some sort of atherectomy. Some people will try balloons at 2 because the difference is small, but beyond 2 for sure, you need some sort of atherectomy. Okay, and then you've used rotablation, but you need more because you still don't have cracks. So that's when you start to think about scoring balloons, cutting balloons, etc. But which one's which? Where do you use what? Right? That's 3 different types of balloons. So let's explore each of those. So here's shockwave, right? We've seen shockwave. It works great. There's no issues with it other than the fact that it's very expensive. It doesn't deliver well. And it comes with only 80 pulses, though there's a new catheter coming out with more. That'll cost more, though. So there is an upside and a downside. This is a great balloon for someone who has a terrible ejection fraction and is not going to tolerate even the potential for slow flow. But that's the vast minority of your patients, right? So there's virtually no learning curve, and it's useful on thick calcium. The problem is, as we talked about, it's hard to get to the site. Forget getting it to a site with bad calcification on multiple sides. And it's expensive. And of course, why would you want to use a cannon to kill a thin layer of calcium that you can get with a particular other tool? So what about an OPN balloon? OPN balloons are good, right? You turn up pressure. Because calcium management is a function of 2 things, pressure and time. You have to put pressure at high pressures on a calcific lesion, and you have to hold it for an extended period. So is there a difference between this balloon and an NC balloon? Well, I mean, an NC balloon you take up to 24, 26, 28 atmospheres. An OPN you might take up to 35. So you're telling me then that 7 atmospheres of pressure is actually the difference between crack and no crack? Well, the answer is yes, but on which patient, right? So let's think about a simple NC balloon. How does, let's go to physics instead, right? Because this is where the evidence, this is what's called finite analysis. This is where the evidence lies. If you have something ductile, okay, so bendy, versus something brittle, like calcium, they're going to behave differently. What happens when you put pressure on something that's hard, right? Let's take this. If I put pressure on the bottom of this, I put pressure and pressure and pressure. Is it going to bend? No. What'll happen to it? It'll break, right? It cracks. Where does that crack happen? It's not here. It's on the outside where you have the most stress because your longest angle is on the outside. So in a brittle material, there is a linear relationship between stress and strain. That's called Young's modulus, right? That's back in elementary physics. So the more stress you put on a brittle material, the more micro cracks will form until a major crack forms, right? And that's when you crack the calcium. How is that different than a ductile material, like a vessel wall? Well, what happens to a vessel wall? It stretches and stretches and stretches, and then it doesn't crack, it tears, right? So it will either dissect or perforate. So it's important now that we've right there, we've separated the 2 types of patients in whom you're going to use simple balloon technologies versus adjunctive technologies. Balloon technologies are good for people who have softer areas of plaque. High pressure or cutting balloon technologies are going to be useful then for people who have brittle materials that you need to crack, because those are the materials that are going to take pressure without tearing and instead result in crack of the plaque. Right? That's just the basic rationale. But when you do finite element analysis, you see that, where this is a simple NC balloon taken up at 20 atmospheres. And what you see is a good deal of pressure, 65.4 megapascals on the outside of the vessel. So what happens then to the rest of this vessel, right? To anywhere that's contacted by the balloon? As you might imagine, there is serious injury to those points in the vessel, right? And that's why when you do balloon angioplasty, this is what you get. You get injury of the vessel wall, you get an endothelial inflammatory reaction, and then you get thrombus formation behind the endothelium. And that's why POBA in and of itself resulted in high layers or high rates of in-stent restenosis, and why when you do POBA and you don't appreciate a dissection, you're at very real risk for closure. That's why acute closure happens. Right? So there's no rocket science here. It's just understanding what the vessel's doing. So separate that from a cutting balloon, where what's touching the vessel wall? Is it the balloon or the athertome or both? Well, of course it's both to a degree, but does the balloon impact the soft part of the wall with as much force? Right? Let's take a cutting balloon up to 20 atmospheres and see what that's like. So now you have point stress, right? You have specific stress on this area of calcium. And it's 3 times what you have with a balloon up at 20. So what you're doing is providing that really high stress on this brittle material. But what you'll see is here, do you see the color? It's not like here. It's still minimal stress on the wall. And that's because the majority of pressure that you're putting on is concentrated at the athertomes. It's not actually injuring the vessel wall. And that's why this becomes a real friend of yours when you're trying to treat calcified lesions, particularly those that are over 270 degrees. Because even if you take a cutting balloon up at high pressures, which you generally don't have to do, you're not going to injure the vessel wall. You're just going to impact the calcium. That's the physics. And so this is what a demo looks like, where at 10 atmospheres, you see, give it time, it'll come, I promise. There you go, you see the balloon going up? Okay, there's 1 crack. Then at 11 atmospheres, 2 cracks, and at 13 atmospheres, it's completely shattered, right? There's your second crack, and there, right? So now you have a shattered calcific segment. So it doesn't require a whole lot of pressure. And that actually also bears out in the evidence, because we worry about high pressure and heavily calcified lesions, right? We worry about the nodules and blowing out the vessel wall. And so what we find is that when you take a 1 millimeter, a 3 millimeter, and a 5 millimeter lesion, okay, and you inflate a cutting balloon in those lesions, what you get is in the 1 millimeter lesion at 12 atmospheres, almost all of them crack with a Wolverine, only 50% crack with an NC balloon. Even in the 5 millimeter lesions, when you go up, you're getting 100% crack, but now you've got 0% crack with the NC balloon. So what you're learning then is that calcium, remember we talked about calcium treatment being time and pressure? Cutting balloons help you cheat that physics, where now you don't have to use as high pressure. Therefore, your injury risk goes down and your efficacy, right? Your efficacy increases. So now it becomes a lot easier to decide what you want to do after you've debulked the lesion with rotablation. The answer is pretty clear if you still have a calcific lesion that is relatively modest in thickness. So if it's around 0.5 millimeter or less thick, you're going to get a better effect by using a cutting balloon, and you're going to do so safely. That's ultimately what we're trying to achieve. And this is the real world evidence for safety. This is cutting balloon versus regular balloon post-rota. No difference in death, no difference in slow flow, no difference in MACE. So it's effective and it's safe. Is it better? Well, interestingly, I mean, those data are now starting to be, they're studied in a randomized fashion now. That trial's happening. But based on the preponderance of evidence that we have in the literature, what we see is that ischemia-driven TLR, right? These are the real revascs, these are the heart attacks. These are the ones that are lower in those who have cutting balloon angioplasty, arguably because of what we talked about, right? When you're putting high pressures onto vessel wall that you're not necessarily going to stent, or that you stent, but that is then injured, you create thrombus. You create an inflammatory reaction which can then adversely impact your result. So this is what happened when we did a sequential 3 millimeter Wolverine cutting balloon. Don't believe me. Believe the imaging. Believe what you see with your own eyes. So this was pre-cutting, right? You see this, there's one crack here, no cracks here. This is post-cutting. Now look. Don't believe me, believe what your eyes tell you, right? So now there's even cracks here, and here, and here, and here, and here, here. Now these are like utterly disarticulated. And so the beauty is, how high do you have to put this stent up? 11 atmospheres. And you post-dilate it at 12 or 13 and you're done. You're not taking 20 atmosphere inflations to try to post-dilate these things because you've already done the work. You've prepared the plaque. That's the secret. It's not about whether you use Rota or Orbit or whatever. It's, do you achieve the result you're out to achieve safely? Do you create cracks in the calcium that's going to allow you to put a stent in and create a maximal sized vessel when you're done? So this was my final pre-deal. I knew that vessel was approximately 376, so I took a 3.5 NC balloon up to high atmospheres because I didn't have a 3.75 available. You can also take a 3.5 compliant. You can take a 4.0 and take it at low pressures, whatever you want. I did the IVUS of the lesion. The beauty is I hate overlapping stents when you don't have to, right? Because we have a demonstrable increase in MACE rates when you overlap metal. It's always better to use one. You also get better flow when you use a single conformable stent because you get less vessel straightening. And there's evidence to support that as well. And so in this 47 millimeter lesion, the beauty was I took a single 3.0 48 millimeter stent. It was they make 3.0 48 Synergy XDs. And that particular stent is designed so that it's hyper expansible towards the proximal segments. So I took that 3.0 to 3.75 without breaking a sweat. And this is what it looked like. Big, huge vessel and done. There was no magic here. It was easy. And it took 24 cc's of contrast. And that too, because I took a diagnostic picture of the right. Right? So there's no good reason to guess anymore. We actually know what to use and when. All we have to do is look at the plaque, decide how thick the calcium is, treat it based on an appropriate technology. So if you have thick calcium, you're looking at after Rota, you're looking at either IVL or OPN. If you have thinner calcium, you're looking at cutting balloon. And then you stent and you're done, right? So it's 2023, right? We don't guess anymore, right? Guessing was for when these procedures first came out. When you ask a surgeon how they get good results in diabetic patients, they don't say that I throw a stitch in here and I throw a stitch in there, and if it leaks a little bit, it's okay, I put some glue on, right? They will take the stitch out and they will redo it, and that's our comparator. So if we're going to then commit to PCI in multivessel disease, in complex lesions, we better be able to deliver as good an outcome as any surgeon can when they're standing there feeling the heart. And so with that, I'll say thanks very much. Hopefully I stuck to time, and I'm happy to answer any questions.
Thank you, Dr. Karla, for your brilliant speech. He has nicely shown the science, meaning that the physics of simple balloon, cutting balloon, and high pressure balloon, as well as how we do rotablation. And from him, I have learned how to do rota by single person. He showed it in my institute, National Institute of Cardiovascular Diseases. But to Dr. Karla, I want to know, many a time we do not see the obvious cracks, but it is told that in micro city there shows many cracks. What is about your idea regarding this?
I don't stent until I see cracks, period.
This year, in Europe this year, they showed that in micro city, it may shows there are many
So if
cracks.
you then can waste the time to do a micro CT on your patient on the patient.
That's not
See,
possible.
so these, I get kicks out of these things. These types of studies are very interesting, and they're very important to teach us about the vessels that we treat, but they're not practical on making treatment decisions. That's why all of the calcium algorithms that are out there are complex, because they try to filter in everything, when instead, as operators, what we're trying to do is make a simple binary decision. And that binary decision is what I'm about to do going to work, or is it not going to work?
That is,
Right.
Probably that is in research.
That's, yeah, I mean,
Yes.
listen, all of this stuff, right? Like the finite element analysis, a lot of the calcium thickness analysis, I mean, like, I do that research, right? So I'm happy to look at it as a researcher when we're doing bench tests on pliability and on ductile materials versus brittle materials, but that doesn't carry forward to the 20 or 30 or whatever rotas that I do on my regular cases, right, in a month. It's that's not helpful to me. What's helpful is, have I achieved a recognized endpoint when I'm trying to treat a vessel? And that is the presence of a crack, because I know that with two diametrically opposed cracks, I'm going to be able to expand my vessel.
Thank you very much. Now the floor is open for discussion, though we are behind the time. Even then,
Thank you for a nice presentation as always on calciums. So I had a question. After we do the rota, we do the ballooning, it's not opening. We image the vessels, and then we see a segment where there is no cracks.
Mhm.
So if we are given the options of IVL and cutting balloon, would you determine it on the basis of thickness of calcium?
Excellent
or-
question. Excellent question. So here's what you do. There's a paper that came out earlier this year. The presence of one reverberation was about 0.6 millimeters. The presence of two reverberations, interestingly, you'd think it would be thinner. It's not. It's actually about 0.7, 0.8 millimeters. And then three reverb is over a millimeter, is 1.1 millimeter. So if you image it and you see one crack, use a cutting balloon. You don't need IVL because it'll split. If you see no cracks, you see thick calcium, so no reverberations, or greater than 270 degrees for more than 5 millimeters, that is not yielding, then you're going to go to a larger burr, or you can consider the use of IVL if you can deliver it. It just depends on what you choose to do. But the vast majority of calcium with a single rota run of an appropriately sized burr will crack, right? And so what you're doing by taking a cutting balloon in those segments where you have no crack is making sure that all segments are fully cracked. And if you have situations where you have not even 360, but 270, but with the presence of a single reverb in any quadrant, just take a cutting balloon and be done.
to see
And
the thickness.
and one thing, when you're taking a Wolverine, which is, this was redesigned to be an imminently deliverable balloon, and keep in mind that's a real NC emerge in the middle. So it's the IFU says 12 atmospheres. Everybody from Boston Scientific, plug your ears, okay? It says 12 atmospheres, but I take it to 24 routinely. What you do is go slowly up to 6 atmospheres. So your atherotomes fully deploy. Then you can go high, right? And then just wait. Give it a second, right? There's too many people I see will go up and then come down. And that's just worthless, right? So go up to 6, go up to 12, 14, 16, 20, 24, and just wait. The patient's fine in front of you. You have time. Wait. And then when you come down, you can come down quickly to 6, but then from 6, come down slowly so that your atherotomes have the time to completely come down. Be particularly careful when you're dealing with calcific lesions that are just proximal to fresh stents or just distal to fresh stents. Because if your atherotomes are deployed and you haven't given the time to come down, you can get caught. And that's the case with any balloon, but with atherotomes sticking out, as you might imagine, you can get caught. So the answer to your question is, if it's thick, so there is no reverb, it's long, and you haven't made any cracks, go with a bigger burr or go with IVL. The bigger burr is cheaper, but you require some technical facility. Having said that, if you've already done rota with one burr, then it's pretty easy. You obviously have the technical ability to be able to do it again. If it's thin, don't bother. Use a cutting balloon and move on.
For evaluating the thickness of the calcium,
Mhm.
which modality you like?
So thickness, you cannot directly measure on IVUS. Okay, you can do it on OCT, which is why that's a good technology. But if you can't realistically pull out 2 different imaging catheters every case, right? Which is why in a case like this, you can't use OCT easily because you can't co-register and the creatinine's high, yada, yada, yada. And for what it's worth, have properly dissected vessels using the contrast injection with OCT, which is why I use it for only niche indications. It works very well. I just only use it at certain times. But you have enough information to be able to infer the thickness where you can start to make clinical decisions. Remember, this is about practicality. It's not about, sifting through inane details like micro CT that don't matter to your day-to-day practice, right? It's cute, it's cool. How interesting, but it really doesn't make a difference
It is
to
not
what you're going
wise
to do.
to shift from one
Right.
device to another device in the same case.
Yeah, it's the practicality aspects are the practicality aspects. Not to say I've done IFR, FFR, OCT, and IVUS in the same case. Okay? And then I had to go to my administrator and explain why I was having a crazy day that day, right? Right? This was very early in my practice, right? So these are the types of things where as you become more and more experienced with complex cases, you become much more practical, right? You're trying to get from point A to point B. You've already got enough stuff going on, right? You start exploring other weird things, like I went around the entire block of calcium. Now I'm going to stent it. Is the adventitia going to blow or not? These are the questions you start asking yourself, as opposed to, are there microcracks? You see it, you see it. You don't see it, you don't see
Any more
it.
question?
Thank you, Karla, for your excellent presentation. We learned a lot for your presentation.
Thank
So I have a question. You tell that there is two things. One is pressure, another is time.
Mhm.
When you gradually increase the pressure, but there is no cracks. But can we increase the time with the pressure? The 20 seconds?
You can. So as I said, calcium is a combination of pressure and time. So if you're going to remember, if you're going to take a relatively low point pressure technology like an NC balloon, you can sit there at 20 or 24 atmospheres as long as you want. You're still only coming away with 65 to 70 megapascals. Where if you're trying to crack something, you want to put as high pressure as you can in as focused a spot as possible for as short a time as possible. So if you then take a cutter and you put 160 megapascals on, you may still need time. You can see that on the angiogram, right, as the balloon opens. But you will likely need less time because you have more pressure at that one point. That's what the data show. And of course, contrast doesn't contain hemoglobin, and when we put stents and balloons up, we block blood flow. So the less time your balloon is blocking blood flow, the better it is for your patient.
Regarding cutting balloon, how much pressure you usually want to reach?
As much as it takes, right? I usually,
As for example,
most of the time, it'll crack between 12 and 14, but as I said, I'll take it to 20 or 24, not infrequently.
like usual.
Yeah, like as recently as-
NC balloon.
As recently as yesterday or day before, I guess, because I was in the air yesterday. All the time.
Sir, we know there are so many techniques like rota, orbital, thermomic cutting on Wolverine balloon. So sometimes we use 2 wire in the calcified lesions, and then we go through the high pressure non-compliant balloon and high
Mhm.
pressure to modify the calcium.
Sorry, the poor person's cutting balloon.
Yeah. So what's your idea regarding that? Sometimes we have found that it's working.
Sometimes it works, but I mean, again, we're trying to get away from the hope strategy, because hope is not a strategy, right?
Dr. Karla, it's the poor man's rota.
Yeah, I mean, it's it's a
We are
hope.
doing and we are getting results. sometimes.
Hope is not a strategy,
Hope is
right?
not a
So
strategy.
so you can take a wire and you can try to inflate a balloon against it, and that is not that dissimilar to the concept of a cutter, to be honest. The athertomes are harder, but wire cores, depending on what core, will flex more or less. But when you do that, you are taking modest pressure to a brittle material everywhere where that wire is not sitting. So if you can magically take 4 pieces of wire and glue them to the outside of the balloon and put the balloon in, then theoretically that will work, but that's what they call a cutting balloon, right? The way they made that for you, right? So you can do it if you want to do it. If you don't have any other option, then use it. But if you have the tool necessary to do the job, use the tool necessary to do the job. Save yourself time. I get these arguments a lot where they'll say, well, why don't you just do this and then do that and do this jugaad and that workaround? And what that ends up costing you is about 20 to 25 minutes, right? So if it costs you 25 minutes, 25 minutes is another case, right? That's another case. Now do the cost comparison. That's easy.
Besides this, radiation is also.
Yeah. So the answer is you can use all kinds of adjunctive techniques, but if you have a tool that's purpose-built for a particular task, generally speaking, this is something I've learned as well, right? Because I remember, I used to early days of working with industry, before I was consulting and designing stuff with them. I'd say, this is stupid. Why didn't you do this? Why didn't you do this? Why didn't you do this? And they'd all be very polite, and they'd smile, and they'd nod their heads and say, that's a great idea. And in their minds, they're thinking, man, you're stupid. We thought about that a year ago, right? The chances are that they have actually thought, because they have a team of people whose only job it is to think about these things, who have probably thought through these things and come up with potential solutions or potential workarounds and why their given tool may address this better. Our job is to figure out clinically where that tool is going to go best, because we as clinicians understand the procedure better than their engineers ever will. But we will never be able to build it better than their engineers will, because that's what they do, right? That's their job.
Any more question? If no question, thank you, Dr. Kalra, for your
Great. Thank you.
brilliant talk. And we have learned